Welcome to the first edition of the Menopause Society Show. In today's show, we're going to talk about a topic that is very current, very relatable, and very important, not only to the clinicians and researchers of our membership, but to the millions of women that we provide care to.
My name is Daniela Hurtado. I am an assistant professor of medicine at Mayo Clinic in Jacksonville, Florida. I have been working in the field of endocrinology and obesity medicine for 6 years. And when I'm not working, I love reading.
Well, welcome. We are so thrilled to have you here, Daniela. We are here today to discuss your wonderful practice pearl that was published, and it was entitled Pharmacologic Options for the Treatment of Overweight and Obesity. And I just have a couple questions for you, given your expertise and reflecting on your practice pearl content. Why do women experience body composition changes during menopause? And why is it mostly in the abdomen?
During the menopausal transition, there will be a decline in estrogen levels, and the decline in estrogen levels will drive the change in fat distribution from the hip and leg area, or what is known as the gynoid distribution, into the abdominal area or the visceral area, also called the android fat distribution. And this is because we do have estrogen receptors at the level of the glutofemoral area that will predispose women to deposit fat in that part of the body. So naturally, as estrogen declines, we do not deposit fat in that part of the body, and instead we start depositing fat in the abdominal visceral area. In addition, as women go through the menopausal transition, the loss of estrogen will exacerbate the lean mass loss that is observed as we age. As we lose lean mass, our metabolism will decrease, and as a result of that decreased metabolism, women will be predisposed to gaining more weight, and this weight will primarily deposit in the abdominal area. So those are the changes that we see with in terms of body composition as we go through the menopause transition.
Wow, very interesting. And I know that it can be very burdensome and difficult for women at midlife when they enter menopause. It seems to be among a prominent symptom that brings women in to discuss symptoms of menopause or body composition changes with their doctors. So recognizing that menopause, the menopause experience and body composition changes can differ across women, can you share how you generally approach women who seek care for body composition and weight changes during menopause in your clinic?
That's a great question. I think one of the most important aspects of my practice is validating what women experience. It is a very common concern. More than 70% of women will have a weight concern as they go through the menopause transition. Validating and explaining the underlying biology is very empowering, because the reality is that these women come to our clinical practice and they mention that they haven't changed how they eat, what they eat, the amount they eat, they haven't changed their exercise patterns, and they are still experiencing these very bothersome symptom or sign, right? So validating their experience, explaining the underlying biology is very empowering. And in my practice, I do a very thorough assessment of their lifestyle, because we do have tools that can help these women prevent further weight gain. If women are already having weight problems, if they have a diagnosis of overweight or obesity, there are tools that I can use to help them treat these diseases. When I do my thorough assessment, I always inquire about dietary patterns. It's very important to me understanding what their dietary patterns are to be able to give them a more personalized advice in terms of what needs to be changed. I also inquire about physical activity. The reality is that the majority of us do not do the required or the recommended amount of exercise that is needed to maintain health, and that can certainly help us minimize or mitigate the weight gain and the changes in body composition that women can experience during the menopause transition. Specifically to menopause women, I do also assess the presence of bothersome vasomotor symptoms, because I strongly believe that if women are experiencing vasomotor symptoms, these symptoms can affect their quality of life enough that it's gonna make it harder for them to successfully go through a weight management program.
What is your treatment strategy? So what options do you provide women generally? For example, if you know they have a history of, say, diabetes type 2 or cardiovascular disease, what would you consider? Or if they have weight changes without comorbidities, what would you recommend?
Absolutely. When we are evaluating someone for weight management, I take into consideration their weight history. For example, I may have a patient who comes to see me because their BMI is 27. Clearly, they have more adiposity in the abdominal area. And even though the BMI is only 27, they tell me that they have gained 20 pounds in the past year. So I may approach that specific patient differently compared to a woman who comes to me with a BMI of greater than 30, meaning already in the obesity category, but they haven't necessarily experienced any weight gain over the past year. So the weight trajectory will tell me how aggressive I may need to be in treating weight problems. We take into consideration BMI, which is a traditional tool that we use to categorize someone with normal weight, overweight, obesity, and then the different grades of obesity. But we are aware that BMI has its limitations. And I do in many of, particularly in my perimenopausal woman, body composition measurements, either with DEXA scan or by impedance, because it will allow me to get a much better understanding of the excess adiposity degree. We use measures like waist circumference, hip circumference as well to assess the risk of developing cardiometabolic complications. So we talked about weight trajectories, we talked about measures of excess adiposity. I also take into consideration comorbidities. Again, it is different if I see a woman with a BMI of 27 who has gained 20 pounds, and in the past year, with this 20-pound weight gain, they have already developed diabetes, hypertension, dyslipidemia, versus a woman that, again, may have a BMI in the obesity category, but they don't have any comorbidities. So the presence of weight-related comorbidities is a very important factor when I'm deciding the type of therapy. The third aspect that I consider when I'm managing weight in women, and we should consider when we are managing weight in general, are patients' goals. I always ask about what other goals beyond the weight number on the scale. And I love that answer because many of those answers, it will change the perspective that patients have when we talk about weight loss. I love when patients tell me, I just want to be healthier to live longer because my daughter is pregnant and I want to spend as much time as I can with my grandchild. Or I want to be able to move better. I want to be able to be able to walk to the mailbox and get the mail without having joint pain. And when patients tell me these other goals beyond the number on the scale, then I can counsel on the fact that many times we don't need to lose a third, 20, 30, 40% of our weight to achieve that. And even with 5, 10% of weight loss, they may experience these benefits that they are hoping to get from a weight loss intervention. And then the last aspect of the weight management plan that it's very important to consider is access and affordability to treatments. Truly, access and affordability, especially these days, play a critical role in treatment selection. And I think all these different points that I have brought up allow me to provide a patient-centered approach to manage weight problems.
Currently, there is a lot of use of GLP-1 medications to treat overweight and obesity. And given that we see a lot of women reporting body composition changes during menopause, are you able to share how you advise women when it comes to the use of GLP-1 medications for menopausal body composition or weight gain?
GLP-1 medications are very effective obesity treatments. I think they are a great tool for many patients who are interested in treating overweight, obesity, and the cardiometabolic complications of overweight and obesity. Like any weight loss intervention, I think it is really important that we understand that weight loss will lead to lean mass loss. And lean mass loss is one of the drivers of reaching plateaus it's part of the metabolic adaptations of the weight reduced state. And we see it with absolutely every intervention: diet, bariatric surgery, endoscopic procedures, and again, we have evidence for semaglutide and tirzepatide that we also see lean mass loss with these medications. And there are studies looking at what can be done to prevent lean mass loss. And the couple of strategies that have been shown to be effective to prevent lean mass loss include adequate protein intake. Studies have demonstrated that in order to prevent lean mass loss, we need 1.2 grams per kilogram of body weight. And if we actually want to build muscle mass, it is recommended between 1.5 and 1.7 grams per kilogram of protein intake. It is a lot. Most of us do not get the 1.2 grams per kilogram of protein in our daily dietary intake. And then the other intervention is exercise. Again, exercise is very important to maintain lean mass, not only the amount of lean mass, but also the quality and the function of lean mass. A combination of cardio activity and resistance training is extremely important. But one question that has not been answered is whether the lean mass loss associated with these medications is associated with any physical function decline. We have some patient-reported outcomes showing that in general, patients after they lose weight, even if they are losing lean mass, they have better physical function. But to date, I'm not aware of any studies looking at actual measures. There are certain measures. We can do the 6-minute walk test, we can do hand grip strength, we can do other testing to investigate physical function. It hasn't been done, and we actually have one study right now that we just started a couple of weeks ago. We're going to look at physical function changes in postmenopausal women using these medications.
Wow, that'll be a really important study. Congratulations, that's going to be excellent. Shifting gears a little bit from the GLP-1 medications, does menopausal hormone therapy help or influence body composition during menopause?
So that's an excellent question. So menopause hormone therapy has been shown to have some benefit on body composition. It doesn't have it has really a modest effect on weight, but it can mitigate the changes in visceral adiposity that women experience throughout the menopause transition. We have published one study. It's a retrospective study looking into how menopause hormone therapy may affect the weight loss response to these GLP-1 receptor agonists. In our published study, we show that postmenopausal women who are using hormone therapy experience a greater weight loss compared to postmenopausal women who are not concurrently using hormone therapy during semaglutide treatment for weight loss. It was a retrospective study, so it has its limitations, but I think this association needs to be investigated further. Recently, at the Endocrinology Society meeting in July in San Francisco, we presented our data on tirzepatide, and it was very reassuring that we saw exactly the same trend. Women who were treated with tirzepatide for weight management, if they were using concomitant menopause hormone therapy, they experienced 35% greater weight loss than postmenopausal women that were not using menopause hormone therapy. And I think the fact that we have seen this with two different medications warrants further investigation.
It's time for the Mythbusters for the Menopause Society show. Here are things that are absolute myths.
I really like your approach of asking patients what they think resulted in the weight gain. I think that's really important because it allows an opportunity for women to share exactly their thoughts with your thoughts, and women may be experiencing or participating in activities that they don't even realize may be resulting in weight gain. So for example, like fad diets or non-FDA approved interventions that they may be picking up. So I appreciate that. That's a nice conversation to start with a patient, sort of like, what do you believe of the origins of your weight gain? That's a really good approach. I like that.
Absolutely, and it is really important to me because I can't provide a holistic approach. A lot of times we hear trauma as a precipitant for weight issues, and it allows me to just provide services that patients may have never had access to that may really support their weight loss journey in a healthy weight.
I was wondering if you might be able to comment on how you may advise mental health support around body composition and body weight gain at menopause for women.
Excellent question. I do believe that women are very affected by weight changes, and it's something that can bring a lot of anxiety, depressive symptoms, and I do believe that is a risk factor for women just get into this vicious cycle of I'm trying, it's not working, why trying, I get anxious, I get depressed. And so it's something that again I assess at every visit. And if I do believe that there are serious mental health conditions, diseases, I do a referral to psychology, psychiatry. We have a multidisciplinary program here at Mayo Clinic, and it allows me to have those services available when needed. I do worry about a history of eating disorders, which may affect my treatment plan as well. And eating disorders are common among women, and maybe not in older women, but a history of eating disorders may also change my approach to weight management. But what I can tell you is that understanding my patient's background, understanding what triggered the weight problems, it's really empowering. And then when we talked about goals in relation to their plan, their preferences, then the conversation shifts. Patients come out of the clinic understanding, okay, I didn't do this to myself. Many people with weight problems, when they come to me, it's because they have tried everything. So I rarely have a patient that leaves the clinic with just eat less and exercise more. Whether it is referral to health coaching, behavior modification, medications, a plan for endoscopic bariatric procedures or bariatric surgery, we have a plan. And not only we have a plan, but we have what if this fails, we're going to try that. So they understand that this process, there is a very big variability in response to weight management treatments. And if something doesn't work for the patient, it's not because they are doing something wrong. It's because the biology of their disease may be different compared to their friend who responded really well just to diet and exercise, right? So we have a plan A, B, and C, and we kind of go through this process every visit just to make sure that they understand that weight problems, overweight, obesity, are chronic diseases, relapsing diseases that are difficult to treat.
If you had one thing to say to clinicians providing care to midlife women in the context of menopausal body composition changes and weight during menopause, what would that be?
I would say that we need to be proactive. Midlife weight gain can be evitable. It's definitely not benign, so we need to manage weight problems early on. If we can prevent them, meaning counseling women that this will happen, it's very likely to happen, we need to start early, maybe early 40s, just to make sure that we understand that as we go through this menopause transition, we're going to have to make important changes to mitigate those body composition and weight shifts. Perhaps just also understanding that the menopause transition, and more than the menopause transition, midlife is a critical window where we can positively influence a woman's long-term cardiometabolic health. We cannot wait until after menopause to treat high blood pressure, dyslipidemia, heart disease. We have to start early on to make sure that we prevent those diseases that can affect overall health quality of life, well-being of women as we age.
It's hot flash time. These are 3 important takeaways from this topic.
Well, Daniela, thank you so much for your time and your expertise today, and your wisdom. You were very inspirational. Your patients and colleagues are very lucky to have you. And I've learned a lot today, and I really appreciate your holistic approach to care. So thank you, and thank you for being a friend of the Menopause Society and our guest on the Menopause Society show.
Thank you, Sarah.